Welcome to our webcast. I'm David Folk Thomas, and today's topic is erectile dysfunction, or male impotence, or in everyday language, when you have trouble getting it up. I think you know exactly what I'm talking about now. And 15 million men in the United States suffer from erectile dysfunction, and of those, only about 1 in 20 seek treatment. That makes this one of the most common untreated medical conditions in the world, and we're going to try to shed some light on it for you and everybody out there. And joining me, a couple of experts to discuss this today. On my left is Dr. Michael Perlman. He's a Cornell psychologist specializing in sex and marital therapy in Manhattan. And next to Dr. Perlman is Dr. Francois Eade. He is the director of the Center for Male Sexual Function at New York Hospital in Manhattan. And Dr. Eade has also brought along a couple of patients with him off camera we'll be speaking with later, Jim and John. And thanks for both of you to join us today.
Thank you.
Dr. Perlman, let's start with you. Just very simply, I said erectile dysfunction, male impotence. What exactly is that condition?
The inability to obtain or maintain an erection so that you're able to perform adequately in order to both please yourself and usually pleasing your partner as well. You know, can you have intercourse is the most typical way of looking at it.
And Dr. Eade, to add to that?
No, I think it's exactly what Dr. Perlman said. It's to the person's satisfaction. And when a person complains of problems with erections or erectile difficulties, then they have the problem. In the past, when a person would go to a doctor, for example, and complain of erectile dysfunction, often the doctor would say, well, you know, it's not such a big deal, or would pat the patient on the back and say, forget about it, you've passed that age. Nowadays, we take that seriously, and we hope that more and more people will come and seek treatment.
In part, just our ability to help people now, I think, has inspired a whole generation of both therapists and physicians to be able to encourage people to talk about these issues because we can successfully treat this problem, and that wasn't always the case.
And Dr. Eade, I mentioned we have Jim and John off camera with us, and maybe you can ask them how they first came to know that they had this problem.
I'm extremely pleased to have these gentlemen here tonight. They're both graciously accepted our invitation. Both these gentlemen, both Jim and John, had prostate surgery for prostate cancer, and they both did very well. And as sometimes happens, one of the consequences of the surgery was loss of erections. They dealt with it, and they are going to share a little bit about their experience with us today. John, do you want to say anything?
John, yeah, when did you knew, I guess, from what Dr. Eade said, that one of the byproducts of of prostate cancer surgery is, you know, impotence. So were you prepared going into this?
I think more than a byproduct, it was a fear. Probably why it took me 3 months to get the operation after the diagnosis was that I was looking for different options, that being the seed, that being the radical, that being ignoring it. When I realized that my age and the situation that I was in mandated the radical, only because of the logic of the future of my lifespan, I went through the decision with the fear of incontinence and impotence. What I was told, however, that I was starting to go through an era of new medications, hence the pill that would enable someone who was having slight difficulty possibly to have the erection, and there were other types of procedures down the road. After the operation, I was healing very well, but I was having difficulty maintaining an erection or getting an erection as I knew it. And there was a insignificant amount of time where I was given Viagra. And Viagra was helping me, but my erection was there, but it was very distorted. And consequently, after all of this research, even on my own, I was informed that I may have, it may rectify itself. But then I came in and I did make an appointment to see Dr. Eade, and it was determined that I had Peyronie's, which is another byproduct of an operation or trauma to the penile area. And there was really no option. This could only it would never reverse itself, and it could only in the future get better. And again, age consequently made me make the decision for the penile implant to rectify that aspect of it.
Yeah, I think one of the key points is that since we have so many great treatments for the problem of erection, that one should be free to choose the best treatment for the prostate cancer. And I find that it's important to be cured of the cancer. And once you're cured of the cancer, then the treatment options, as we will see later, talking to both Jim and John, are really fabulous. And they've done so well with it, and I think that's the key point.
We're talking about medical causes. Dr. Perlman, what about psychological causes for erectile dysfunction?
They can run the whole gamut, and I think part of what we're seeing here is really the intelligence of the patients in recognizing that if you have a prostate cancer surgery and subsequently find yourself unable to get an erection, it's a good idea to go back to that surgeon and also speak to a urologist and have a full medical consultation. However, so many men as they age presume erroneously that they're supposed to have automatic erections, that they're supposed to be looking at their partner with the same degree of excitement and interest that they used to have and spontaneously have an erection as if it's some kind of Peter meter. So the most common cause of erectile dysfunction is essentially insufficient stimulation. We don't get the direct friction, if you will, to our penis that we need in order to obtain and maintain the erection. Fatigue, another common cause of erectile dysfunction. When people say, hey, I'm just too tired, it's not just some lame excuse. It's a reality because that affects your physical capacity. Same thing with negative thinking. So relationship issues can somehow impede a couple's ability to be able to function completely and correctly. And then there's some other more deeper, if you will, psychological causes. But the most common ones are really insufficient stimulation, negative thinking, and fatigue.
Do we know what percentage of patients with erectile dysfunction is it caused by psychological or physiological?
Most of us at this point in time have adopted a much more sophisticated view, a new paradigm, if you will, where you can see both the psychological and organic causes. Because even in cases of organic disease, like these gentlemen have, the concern that develops about that will cause a complete dysfunction, even if there was partial functioning, as John described. So we all have to work together, which is part of why Dr. Eid and I are here together tonight.
Jim, let me ask you a question. John, you and John both had the prostate surgery, prostate cancer. Now, do you feel there was any sort of emotional attachment, as we've just discussed, a psychological component to your erectile dysfunction, or was it strictly the medical procedure?
Well, when I was first diagnosed with cancer, I was worried about living. That was my main thing. And at my age, I'm fairly young. And I went to 2 different specialists, and they both recommended the surgery. So I really wasn't too worried about the incontinence or the sexual dysfunction until I wanted to get the cancer out of my body. So after I had the operation, and the doctor told me basically, worry about your PSA level, which is, again, I was going back every month. And luckily it stayed almost at 0. Then the incontinence, I was incontinent for about 3 or 4 months. I conquered that. And the next thing was the sexual part of the operation. And I was very fortunate to go hear Dr. Eid at a man-to-man meeting. And I was very impressed with him, and that's the doctor that I wanted to go see. So I made an appointment with him, and whatever he suggested, which was the penile implant, after I tried Viagra. It's been over a year since the operation. Went from 50 milligrams to 100 to 150, it didn't work. And it didn't work, so I got the penile implant, and everything seems to be fine.
All right, Jim, thanks for sharing that. We're going to wrap up very quickly. Dr. Eid, let's very quickly talk about other physiological
yes, when we talk about the 15 million men with erectile dysfunction, a lot of these patients have a physical cause, and the physical causes have to do with the vascular system, with blood flow, insufficient blood flow going to the penis, and it has to do with high blood cholesterol levels, diabetes, high blood pressure,
smoking,
tobacco smoking. 68% of all our patients who don't have surgery and have problem with erections are tobacco smokers. Now, there's also patients who have multiple sclerosis, patients who've had any sort of radiation, chemotherapy, colon surgery, bladder surgery, have problem with erections. And then we also have patients with spinal cord injury. Males have neurological inability to have an erection.
Also, in addition to these direct medical causes, sometimes, unfortunately, the treatments for the necessary treatments for medical conditions such as high blood pressure, depression even, approximately 70% of people suffering from depression will also manifest some kind of sexual dysfunction. So we have to take a look at the medications the person is taking in order to help other kinds of problems, because frequently they can cause a sexual problem as well. So this is how we work together.
That's all the time we have for this webcast. I want to thank my two experts here, Dr. Michael Perlman and Dr. Francois Eid, and also to Jim and John off camera. We hope you've learned a little bit about erectile dysfunction, impotence, and look into it more if you need to have more information. Thanks for joining us. I'm David Folk Thomas. We'll see you next time.